great to be here. It's the turnout is fantastic, so I'm happy to be part of presenting some information about genetic testing, especially with Derek. Let me introduce myself a little bit first. Susan Walther, as Grant said, I'm from the University of Pennsylvania. Our laboratory does the chromosomal testing version of the genetic testing. I've had a long-standing collaboration with the Wills Eye Institute, specifically Carol and Jerry Shields, for the ocular oncologist there. And so my role with them has done some pre-test counseling, but mostly post-test counseling. So when that result comes back, sitting down and explaining, what does it mean? What do we do with this result? And we work closely with referring patients to Dr. Sato, who you heard yesterday and you'll hear again today. Our laboratory does more than just ocular melanoma. We do a lot of other genetic testings, and so my other hat is to work with physicians to set up genetic testing. We do 9 specific genetic disorders and 2 prognostic tests, one for heart disease and the other for the ocular melanoma.
We're going to try a tag team approach here. You're recording it for that. Okay. So we'll see if we can reach everybody by voice appropriately. My name is Derek Maetzold. As Grant said, I'm the head of a company called Castle Biosciences. So I guess the first thing is I have a certain conflict of interest with this discussion and presentation, et cetera, because the test that we offer in this area is the DecisionDx-UM gene expression profiling test in our laboratory. Phoenix services those biopsy samples when they come in. So that's just kind of a fair disclosure standpoint. I thought it'd be important to maybe have a couple of slides on maybe what our goal is as a small company out in the West, and where ocular melanoma fits into this equation, I guess, in terms of what we try and go ahead and offer and serve. We started up Castle Biosciences in mid-2008 with the sole goal of really focusing on diagnostic and prognostic testing for rare cancers. And the reason for that was because if you look around for more common cancers, the reality is that there's a lot more interest, there's a lot more research, there's a lot more people working in those areas. And our belief was that the investor group and I had all worked in smaller disease states, was that maybe we can go ahead and partner with some institutions like MD Anderson or WashU or Indiana University and work with some researchers who are developing good tests. And rather than have those tests be limited to you happen to be blessed enough to go ahead and live in Houston so you can come to MD Anderson for care, is make those available on kind of a pan-US basis as opposed to being center-specific only from a patient care perspective. And so that's kind of been our philosophy in terms of rare cancer. We have a couple of tests available and 4 more that will be releasing over the summer of 2012. But as it relates to ocular melanoma, we were contacted a couple of years ago by Washington University to go ahead and look at this test, which Dr. Bill Harbour was developing, called the gene expression profiling test. And in contrast to sort of genetic testing, where you're looking for either chromosome or gene differences, this is really kind of taking a snapshot or a footprint of kind of the milieu of the tumor overall. And the issue that Dr. Harbour's group had was that he had developed this test over the last decade and was essentially running out of research funding because he had enough people sending him samples that wanted to have this tested for clinical care purposes, and that doesn't quite match up with research funding. And so they were looking for a laboratory that would be interested in taking something which wasn't going to be running 100,000 tests a year, but maybe a couple thousand. Would you take care of our baby, make it available? And we said, this actually fits exactly what we think we can do. And so we licensed in that technology from him and made that available, I guess, right at the end of 2009, early 2010. And as Dr. Samuya mentioned earlier, the whole milieu of sort of where does testing come into assisting with better prognosis or staging and more accurate information is really quite new to this whole area here. I don't know how long Penn has been doing this, maybe 3, 4, 5 years, maybe less than that. But it's a sea change for patients who are coming behind you, I guess I would say. And our hope, of course, is that downstream, the information about who may be at a higher risk can be used to make changes in care today, can be used to go ahead and perhaps enrich and accelerate clinical trials and hopefully improve outcomes over time because you have an enriched population. And for those patients who might have a lower risk tumor, is to be able to say lower risk does not mean no risk. I mean, let's understand that first. But lower risk also means there's a different thing going on here. So those are really two different patient populations, as opposed to having everybody be treated as one, I guess, was the goal. We think there's around 70 centers in the U.S. that treat ocular melanoma. Now, 70 is far greater than the 15 or 20 which Colleen talked about, and so let me differentiate that. There are probably 15 or 20 centers where you have individuals who were trained in ocular oncology, where they spend half their time, full time, in this area of care. Then there's an awful lot of other physicians, ophthalmologists, and retinal specialists out there who feel comfortable either performing an enucleation or even plaque radiation, who don't necessarily refer patients into a larger center. One of the opportunities that we felt should be taken from a testing standpoint was that rather than just limiting it to those few centers where you have full-time people, is if a patient's care is going to be local, then that patient should be given the same level of care as if they had the resources to go to a major center. And so that's kind of where we get this 70 number, is our estimation about how many smaller centers and large centers are out there. And most of them right now offer this test and order it up on kind of a fairly routine basis. We also were working with Dr. Harper when this discovery of this BAP1 gene was talked about. And one of our expectations was to say, well, number one, it happens to be in the same little thing called ocular melanoma. So it might make sense to combine it. Now, we don't quite know what that means from our standpoint, and we are simply a sort of testing service company. So we don't do clinical trials, we don't treat patients directly, so we're servicing as a healthcare provider your physicians. And our sense right now, and it would be interesting to go ahead and see how far along the community's come in the last year and a half since this discovery was made, but from sort of a prognostic testing standpoint only, our perspective with Dr. Harper's group and other colleagues is that the gene expression profile test is likely to be shown to be more accurate and more reproducible than just doing that one testing at this point in time, and that we would look to go ahead and finish up some research work on that, perhaps make that available for just the high-risk patients if it can somehow help therapy directed clinical trials, I guess you would say. And so we thought we were not going to really speak to that at all. We assume that we've spoken to later on today, but we'd focus more on prognostic testing as a recent advance, I guess you would say, in early diagnosis of care. The other service model that we offer up is interesting here. So when you deal with rare diseases of any kind, insurance companies by and large don't know really how to package it. So if you have diabetes, you have heart failure, you have high cholesterol, they sort of say, okay, well, this is kind of normal care because I have hundreds of thousands of patients underneath my plan, and this is kind of what's given. And if they see outlier care, they can kind of pick it up and say, well, is this really something that's experimental, is it research, or is it kind of standard of care that we should be doing? And we recognize when we started at Castle Biosciences, having worked in the pharmaceutical side of rare cancers, that's a haul. It takes work to get insurance companies to review things, to approve things. And so one of our funding approaches was to say, number one is that the first thing was to make sure that every patient was aware of prognostic testing at the time of diagnosis. It doesn't matter if that's appropriate for you as a person. It doesn't matter if it's appropriate for your doctor to go ahead and be comfortable doing it or not, but at least have the information to make a decision. And what we didn't want to have put in that decision factor was, gee, what's the cost of my test going to be, or will my insurance cover it? Because that might take a day, or it might take 2 months to get answered, and you're looking at getting primary eye treatment quicker rather than later. And so one of our models is we have a separate subsidiary in Castle where we just have a charitable fund. And our perspective has always been that if a physician or a patient think testing is appropriate, we'll do the testing, and we will fight to try and get reimbursement. If you are uninsured, we'll take that out of our charity foundation, but we're going to go ahead and make sure that we don't not process a specimen on one order because of some cost differential issue based on insurance plan changes. So that's at least something that we've offered across the board as a company. And thankfully, with the support of the physicians who are ordering this test and the documentation and medical records, we are able to go ahead and get reimbursement on a more regular basis right now without having to say, as a patient, that's sort of over the wall and your issue. And so that's just kind of as a philosophy as a company we kind of go forward on, not only just in ocular melanoma, but across the board from a testing service. And that was sort of my up and running part. Am I going? Okay. I'll continue, I guess, a couple more slides. Before I do that, my understanding is that and I'm not a patient, by the way, so I can't, I'm on the outside looking in. My understanding is that most everybody here is either a patient or a caregiver out 2 months, 6 years, 15 years, some kind of stage. My main need, I guess, is that we still continue to get, on a monthly basis, too many calls from patients who have had plaque therapy, and if they're out for 2, 3, 4 months, you know, the sort of organization of your life has come down, and you're planning what's next, and they run across genetic testing, either chromosome 3 testing or ours, and saying, gee, I'd like to have this done. And from our standpoint, as Colleen mentioned earlier in the earlier talk, from an RNA stability standpoint, we need to have a signature tested on live cells. So post-plaque radiation, we have no idea what that does or does not do to that, and that really makes our test unreliable, and we can't perform those from just a clinical use standpoint. We wouldn't mind doing some research work in that area, but in terms of relying on it clinically, that's just something we can't do. So one of the goals when I called Grant at the first part of this year was to say, I don't know if this group will be having a conversation at the end of our talk this morning or in the hallways this evening, but what I'd like to do is to make sure that, first of all, that we don't get any more of those phone calls, so that when patients are newly diagnosed, the materials are there on the internet or in the doctor's offices, and they're making an informed decision up front of, is this right for me or not? And that's a personal choice. And that's a choice that we shouldn't be having to say, you can't make that downstream. So one of our goals here was to kind of walk out with saying, okay, well, where did you get information when you were in your early stage of diagnosis? Where did you not get information from? What else could we be putting together to make sure that stuff is where you're looking at this at the right time? So that's kind of my personal self-interest in walking out today in the next couple of months, is to figure out what can we do in this sort of needle in a haystack so that all the needles are put together in one area of the haystack. Makes sense? We should have probably booked 4 hours now. Most of my slides here. So a couple of the questions that Susan and I hope we can be able to answer for you over the next 20 or 30 minutes or so, and perhaps this might prompt you. And one of them is why is prognostic testing offered? I think that was discussed quite importantly by Dr. Celia earlier. We'll kind of give our take on this from a genetic counseling standpoint, testing service standpoint. What are the options out there? There aren't that many, and thankfully I think you've got nice high accuracy tests, but there don't have to be a lot of tests out there, which is a good thing from just a confusion and selection standpoint. When does one have to go ahead and decide about testing? We'll go into the plaque patients versus the enucleated patients, because there's different options there as well. What are some of the risks? I'm not a physician, by the way. I've never dilated an eye. I've been on the other side of the equation. But we have stolen a couple of slides and a reference just talking about risks that are there from a complication standpoint. We'll refer right away to the ocular oncologist without stepping into clinical care. And then, what are some of the reasons from a survey standpoint that physicians and patients want prognostic testing to be done? And Susan had done a very nice study at UPenn with her patient base. We kind of walk through those answers and see how that lines up with the group in here. As I was telling, I guess Mrs. Allen earlier, we completed just last week a review of our Medicare cases from 2010-11, I guess, for Medicare reimbursement purposes, looking at how do physicians write down, are they doing anything with these test results? And so we didn't go out and interview these physicians, we just took the medical records for reimbursement purposes and said, is there documentation here saying, I had this test ordered, I got the results, and did you do anything with them? Now, maybe the most important thing for a patient is I'd like to know my prognosis, but there's other opportunities like, is there information here about changing surveillance mechanisms, or how frequently do I see my doctor? Do I go to a medical oncologist right away, et cetera, et cetera? So we'll kind of go through that briefly at the end as a stepping stone of Dr. Hogan's presentation. Any questions?
Yes.
Oh, okay.
You say you have about 65 to 70 centers. Are those ocular oncologists that you have informed about your test?
There's 65 retinal specialists, ocular oncologists, and ophthalmologists who send in orders for our test.
Is there a way to make it available in public so that, because we have a lot of problems finding such people. If you maybe make it available, you make it so much easier, and you will probably get a lot more tests from that done that way. If you make it more available, that kind of information, because I found Dr. Harbour by chance in his test like 2 days before my proton. And a lot of people probably find the biopsy story too late to believe it.
Let me hold that and come back about halfway through, because actually that'll be perfect to go get into some details. Yes, ma'am.
I was going to ask if you could give us a list of those places.
We should. Let us hold that too. Hold on.
Okay.
These are great answers, aren't they?
I know that after proton beam or radiation, that the biopsy is unreliable. But what is your opinion about doing a biopsy on a frozen specimen from an enucleation 5 years ago?
Yeah. So maintain under. So from a RNA gene expression standpoint, we've done some of those.
Yeah.
Some of those were actually used for the development of the test by Dr. Harbour's lab. So he had taken enucleotides and then taken part of the tissue and flash frozen like that. If you're talking about personal experience or you, then I guess the question would be, was that maintained at -80 for all 5 years? Is there a good chain of custody so that everybody's comfortable it wasn't thought out accidentally or whatever? Then I would say that's a conversation we go and do, and that'd be very similar to a nucleotide that was preserved in formalin and paraffin, same kind of process that I would assume from a DNA standpoint.
Right, so both the chromosome and the RNA expression could be done on a frozen sample. We always prefer a frozen sample over a paraffin-embedded sample just because of the quality of material that comes out. Maintenance of a frozen sample is important, as Derek said. The more important question is to ask, we can get an answer. It's the timing of how far out you are from that diagnosis, of how useful that information is going to be in terms of your screening and where you are with having developed metastasis. The goal with the genetic testing is to have that information going forward to plan for that medical management. But we are always willing to talk to a patient who has that question and go through the details that are specific to you. So there's a technical aspect. Yes, we can do it. Should it be done is also a question that should be answered.
Can it be done after 5 years or after 10 years?
If it is,
In the ideal
with the frozen
situation.
sample, yes. With paraffin embedded, sometimes the years out from how long that's been in paraffin doesn't yield enough material to get an answer. So it depends on what the specimen is.
Thank you.
Any more questions that I can't answer?
Are you finished with your list?
That was just a list to go in promptly, so
Well, I
you
think
can keep
down
going.
to one patient's one. Where I was, it was not offered. The ocular oncologist, who is world famous, does not believe in it. He thought it was risky. And so, well, I told him why I wanted to know. Of course, it is, you're not talking about that. In terms of there are now adjuvant therapies, a number. And some of you know about many, and some of you know about a few. And in respect to that, of course, if you are a high risk factor, then you can take a high risk adjuvant therapy. If you're a low risk factor, maybe you wouldn't want to do that.
Exactly.
Now, Yervoy has been tried also in ocular melanoma patients as an adjuvant therapy. It's got some really, really nasty side effects. And so if you're class 2, you probably say, I don't care, because I'm going to die anyway. I might as well try it. If you're class 1, you probably shouldn't try it. So that, I think, should be, at the current moment in time, one of the primary reasons why you want to know. Otherwise, there's nothing much you can do with the knowledge, unless you are looking for treatment opportunities. And I'll tell you who it was.
Wouldn't genetic testing be helpful to those of us who have children, cousins, siblings, grandchildren,
Generations.
and
I'm
so
sorry.
on?
Let's go through some of the slides because we're going to answer
'Cause you're gonna get
all
to
these
that. Okay.
questions. Yeah.
Thank you.
So then it won't be a do-over.
So one kind of important definition piece to go and keep in mind is there are sort of tests, and tests could be looking at the size of the tumor, a clinical factor test, or it could be a test like a genetic test. These are the milieu of what your physician and laboratories use to try and define what is the exact disease that you have. And then the second piece of that is once you have a correct diagnosis would be, what are we looking at from a progression standpoint? Is this going to be kind of a quiet tumor, or is this going to be a very aggressive tumor? It might respond to certain therapies. And so I thought it was important to have you understand that there were sort of diagnostic tests or testing or evaluation done by laboratories, by pathologists, by your physicians. And those are really focused on locking down the correct diagnosis of the condition. And then there's a separate linkage, which is sort of prognostic testing that we're talking about here, which is really looking at what might happen from day zero going forward on a population basis. So that you don't say, well, everybody is in one big pot. There's actually a couple of pots out there, and that's an important differentiation to know, as you talked about, sir, what's the risk benefit to me from an adjuvant therapy standpoint, surveillance standpoint, trial standpoint, et cetera. And if you don't have that information up front, it's hard to really get a balance on the risk if you're at low risk or high risk. So why is this being offered from a testing standpoint? We already talked about the prognosis application. What are the chances of progression? At this time, when it comes to ocular melanoma, although things are changing very rapidly, I think it's safe to say that there's no real treatment response test or treatment response marker out there from a biomarker tumor standpoint. But even as Dr. Spool, you talked about, things might be coming fairly quickly here in the next couple of years. So the main focus here really is the diagnosis of the disease correct, and then what's the prognosis, so that you can then plan differentially based on individual risk. And in cancer, at least, this knowledge, sort of generally speaking, is staging. And so staging for ocular melanoma, it can be, or was before, tumor size, ciliary body involvement, pigmentation, et cetera. It can now be included to include chromosome 3, 6, or 8 analysis, so gene expression profiling analysis. All that kind of gets put together in something which is called staging by the oncology community. Importance of staging here, this is why we're going to hold the questions. Some slight repeat. Poor staging usually results, as we said, in sort of a one-size-fits-all, because you really can't tell accurately who might be at greater risk or less risk of things going forward. And so that's one of the important things about getting everything right, so that that's that one can go ahead and do. And good staging accuracy usually ends up having a nice improvement in how patients are cared for, either today or improving clinical trials later on, because you have a much tighter focus, similar risk patient population you're dealing with, and it takes all of the wasting time out of the long-term trial plan. So the implications of sort of ocular melanoma diagnosis in terms of staging, there was an earlier presentation by Colleen in terms of obviously options out there from a pharmacological standpoint. The staging perspective is that I think there's no doubt that the increased accuracy with the genetic testing approaches today are greater than what we had before, just looking at tumor size and eye size, et cetera. After recovery and follow-up, then the question usually becomes, okay, do you refer everybody out to medical oncologists for follow-up? Do you manage some of that surveillance yourself? Is there adjuvant treatment plans to go ahead and consider? Are there clinical trial options we can get into earlier on if you're a known high-risk individual patient? And again, whereas this is sort of a 2012 is a sea change of opportunity, because these are just now becoming available on a much greater basis, and hopefully we can have opportunities for adjuvant trials or clinical trial enrollment based on high-risk classifications that will help accelerate progression forward.
So at the University of Pennsylvania, the majority of patients that I see, as I mentioned, are through the Wills Eye Institute. And so it quickly became apparent as I was doing the genetic counseling for these results.
Can you get close to the mic?
Sure, sorry. As I was doing the genetic counseling for these patients, the question became, why are people doing the testing? And I'm going to present some data throughout the rest of the talk of what patients have told us. But in jumping off for the rest of the talk, I wanted to present this first question. One of the things that we ask patients is, if you think about the time that you were diagnosed, what were some of the most stressful aspects of hearing about that diagnosis? And there's a list of things here, but most importantly, I just wanted to highlight but the majority of patients said the diagnosis itself, being told I have cancer. That just starts the whole pathway of stress, obviously. And then one of the others is the vision loss. So that is a big concern, that patients wonder how the treatment that they've chosen is going to affect their recovery and their retention of vision. And then the basis for this talk is that many patients did say that thinking about what the future holds for the risk of metastasis. So regardless of whether somebody had genetic testing or not, they are told that ocular melanoma has the risk of metastasizing. And so, again, this was comparing patients who actually had declined testing versus those who had accepted it. But the rates of these answers were very, very similar, that worry about the risk of metastasis is present from the time that you're told of the diagnosis. And the rest of the talk, we're really going to focus now on what is the risk of metastasis, what is the genetic testing telling us, and then I'm going to go through some data at the end where we went back and looked at how patients are actually using this information. So if we look at the staging evolution of ocular melanoma, as Derek had mentioned, most of the times when people were diagnosed, at the University of Pennsylvania, we've been doing genetic testing since about 2005. It's gotten much improvements since about 2009. But essentially what most patients were told at the time of diagnosis were we looked at the clinical features. So certainly the larger size tumors that's already been mentioned, the location. So a tumor that's in the ciliary body has a higher risk than something that's found just in the iris, for example. And extrascleral extension. So the larger it is, the more risk factors there are going to be associated with it. But then we went on and we actually started looking at the cells from these tumors, and then we added the pathological factors. So now we tell people, if we can, epithelioid versus spindle. So that's looking at the shape of the cells under the microscope, and we know that epithelial cells are a higher risk factor than spindle cells. So then we went back and said, all right, if we look at the genetics of the tumor and we look at the risk of people that have developed metastasis, is there something that's telling us on a genetic level that we could have predicted that risk for somebody? And so we started to find chromosome 3 routinely came out, and we were able to quickly differentiate disomy, so maintenance of the 2 copies of chromosome 3, versus loss of 1 copy, what we call monosomy of chromosome 3. And the 1 copy, the monosomy, is associated with a higher risk of developing metastatic disease. But even that, the profiles of who was metastasizing, it wasn't, black and white. There were a lot of gray areas that we wanted to fine-tune the testing. And so now in 2012, we're at the point where we're doing gene expression profiles, so RNA-based, looking at the gene expression, looking at the biology of the tumor, versus also the chromosome testing, so looking at chromosomes 3, 6, and 8. We've added the number of chromosomes that we're able to look at to be able to fine-tune that risk of metastasis. So what are the testing options? Let's compare. We hear all, you have a decision. Do we do chromosome testing? Do I do RNA expression profile? And what's the information that's going to come from that? The chromosomal factors are DNA-based. So that is done at the University of Pennsylvania. Basically, we're doing analysis to look for monosomy of chromosome 3. So we're doing analysis of the chromosomes, but what we're looking for is the high-risk features. Our loss or monosomy of chromosome 3, and amplification, duplication, extra gene genetic copy number on chromosome 8. And we're comparing that to a normal cells. The normal cells comes from blood samples from you. So essentially what we're telling you is the DNA, the gene copy number, and that's fairly constant. Anytime that you were to look at that tumor cell, the chromosome result would show a fairly constant result. And so we're telling you the copy numbers of the genetic material, and we have found that the result is very reproducible. If we look at the gene expression profile, this is the test offered by Castle Biosciences. It's RNA-based, so it's just a different source of genetic material. And they're looking at a profile of genes that have a different level of expression in the tumor cells. So it's not necessarily something that has to be compared to normal tissue. We can give you an answer based just on the functioning of the tumor itself. And the result reflects a snapshot of how the tumor cells are functioning. And that snapshot is enough to tell us what is the overall aggressive biology of the tumor, what's the risk of metastasis. And again, they have proven and has shown that the results are highly reproducible. The take-home message from this is both tests to determine the risk assessment for determining metastatic disease, and we quote that within a 5-year risk from the initial diagnosis. We've heard from the previous talk that the screening is lifelong. The risk for metastasis can occur beyond 5 years. It's that the data that we've looked at in correlating these genetic results and the risk of metastasis, most of that has been done in following patients out for 5 years from the initial diagnosis. So taking context in terms of what the research is telling us, what we've been able to do so far, part of that is because we keep improving these tests. So every time we improve a test, we start again from zero and need to follow time out. The risk for metastasis, the risk for metastatic disease, is independent from the treatment that you've chosen. So whether you've had plaque radiotherapy or you've had enucleation, there is a risk of metastasis, and the genetic result can help you determine that risk. And for ocular melanoma, the chromosomal factors do correlate with the gene expression profile. Both tests have been shown to classify the tumor biology as low risk or high risk. Going back to the initial slide that looked at diagnostic versus prognostic, it's an important concept to remember. We're giving you a risk assessment, a prognosis. You've already been diagnosed with the disease. We're not giving you a 0 or 100% of whether there's going to be metastatic disease after the initial diagnosis. So if we look at what the tissue sources are for the testing, if we do the chromosome 3, 6, and 8, SNP-array is just another way of saying that we look at DNA. We can do it on fine needle aspirates, we can do it on a frozen specimen, we can do it on a paraffin-embedded tissue, and we're using a venous blood draw, so blood just drawn from your arm, that is your control. No one can survive with monosomy chromosome 3 or amplification of chromosome 8. It's not compatible. It's something that's going on just in the biology of the tumor. So we're able to use your own blood cells to tell us what the chromosome picture should look like as compared to the tumor. The DecisionDx-UN is the expression profile, the RNase-based test. They're doing it on a fine needle aspirate or on frozen tissue paraffin, and it's looking specifically at the biology of the tumor. So a bit of a difference there that they're able to give a result just looking at the function of the tumor. Important point. Majority of patients are treated with the radioactive plaque, and so the decisions about whether to do genetic testing must be made before the radioactive plaque is placed. And a little bit more time to think about it if you've had enucleation and there is still specimen available. And I think that's part of the stress in deciding about genetic testing. As you're diagnosed, most physicians want to get in there and do the treatment fairly quickly, and you need to make a decision about whether to do the biopsy and get the prognostic information. So what are the risks? People always ask, and this will come up in some of the survey data that actually kind of surprised me, and I realized somebody mentioned about education. I realized that sometimes we didn't make it clear to patients what the risks were and what the safety features were for doing the genetic testing. So yes, when you do a biopsy of the tumor, there can be subretinal hemorrhage, a small number of cases, about less than 5%. Sometimes there's retinal detachment. In my experience, it's been, I don't know of any of the patients that I've seen have had a retinal detachment from a biopsy, but yes, that is present. Inflammation in the eye, the actual biopsy can cause enough irritation that there's chronic inflammation that's left behind. People have talked about needle track seeding. So what that is talking about is when you put the needle into the tumor and you're removing the cells, that you're actually drawing out and kind of seeding along that needle line. Again, it's also a very small risk. And the fact that you would cause any kind of tumor to go beyond the eye is also a risk factor. However, when we look at the actual patient population and we look at the risk of metastasis from patients who have had the genetic testing through a biopsy versus those who have not, we do not see a difference in the risk of metastasis. So we safely say to patients, we are not going to cause you to metastasize if you choose to have the genetic testing. And again, from experiences from both the centers that we've worked with, the risk of complications is very, very small. So again, you've got a lot of things to think about when you're treated. We try to encourage patients that if you want the prognostic information, the pros of that might be way more heavily the possible complications that would occur from doing the biopsy. Okay, so let's talk about why do we want this result? I've mentioned technology. We can do pretty much anything you want to do in the lab now. Taking it back to patient care, why would a patient, why would a physician want this result? I had looked at a survey of patients who at Wills Eye Hospital, so I will say it was at one center, and I compared patients who had declined the genetic testing and those that had accepted the genetic testing and asked about some of the questions why that decision was made. No patient in the study had developed metastatic disease, so all of them are fairly close out from the initial diagnosis. I'll go through this slide quickly. You kind of don't have to pay attention to a lot of the numbers. But not surprising, if we look at whether people declined or accepted genetic testing based on age alone, under the age of 60 years, about 60% of patients declined, and about 70% opted to undergo genetic testing. Kind of not surprising, sometimes older ages people feel like it's in God's hands and it's a wide range of that we see. But as I say, everybody's concept of age is different, so just a statistic. And then over the age of 60 years, 40% of patients declined, about 29% opted for the genetic testing. So we do see a bit of a bias that people under the age of 60 are more likely to consider having the genetic testing for a prognostic indicator. And then if we look at both groups, more than 60% of patients that we interviewed were about 6 to 12 months out from the initial diagnosis. So still fairly new in terms of dealing with the diagnosis. In the question, if we asked, if you decided no to genetic testing, what influenced your decision? And this is going to be different. Keep in mind, it's all the patients that had testing through the University of Pennsylvania. We do our billing a little bit different. And there's some other costs that are wrapped into it in terms of how the ophthalmologist does the sampling. So the majority of patients did say that cost was one of the deciding factors for them. But more importantly, I want to look at the slide that if we say patients who had decided to opt for genetic testing, what went into that decision? And most patients did say that they wanted additional information about the tumor. I was surprised by the number of patients who told me that they didn't care whether it was used for their medical management. They just wanted to understand what was going on in that tumor, which always warms my heart because I love people who are interested in research. So I thought that was really neat that people just thought it was important to understand what was going on. Obviously, they're getting a result. And so using that result, most patients said that they wanted to use that result to guide their medical management. If we look at asking patients, so at this point we've asked patients, how do you feel the genetic information has been useful to you? Most patients have said, I feel that knowing my risk for metastatic disease is important as I plan for the future. So many patients told me, I had several patients actually who had put plans in place, financial things for their children in place. I had several patients who told me, everybody says you should have a will. It finally made me sit down and put that in place. So when we talk about the future, we're not just talking about medical management. We're talking about what would be important for you as a person, things that you want to do. I had a patient who bought a new car that she'd always wanted. I think these are important things to consider. What would the information mean to you in terms of planning for the future? Majority of patients did say that they felt that the information had prompted them to seek additional medical advice. That kind of got wrapped into seeing a medical oncologist. Many of our patients do go over to see Dr. Sato for a consult. So again, really getting some other input on what do I do now? What do I do for screening? Help me put a plan in place. The other part that I think needs to be considered with genetic testing, we focus a lot on giving somebody a risk for metastatic disease. And what does it do for your medical management? But I think another important thing to think about is sometimes we get to give people good news. We get to tell them that they're at low risk. And the low risk group has less than 10% risk of developing metastatic disease within the 5 years from the initial diagnosis. That can be compared to greater than 50% risk in the high risk groups. And so we want to also, patients who had been in that good group, felt appreciative that they were able to have that reassurance both for themselves and for their families. And so I think that needs to go into the decision-making process. And I always say to patients, we always put a plan into place to plan for the worst, and we hope for the best. And when the genetic result comes back, sometimes people get that good news. So that is important to the thought process. All right, so we asked patients what they thought was useful about the results. Then we went back and asked the patients, how do you think your doctor is using these results? And about 73% said that they felt that their physician had considered the results in determining their follow-up medical management. So I was very reassured about that. The majority of patients wanted information to guide their medical management and then had the support of their physicians to make those changes. And again, sometimes insurance can come into it. Those people that fall into the low-risk group may get screening less often, and that can be a benefit. And obviously, you want to get the screening more often if you're in the high-risk group. About 12% of patients said that they had not shared the information with their physician. And improving further from that, the majority of patients who had not shared it were patients that were concerned about insurance discrimination. They had not yet seen a medical oncologist and didn't feel comfortable trying to have the primary care figure out what the result might mean. So there were a lot of things that went into that. And as I tell patients, insurance and discrimination, we can talk about that if there's more specific questions. There are laws in place that protect you against that now. So we try to work with patients on, if you have the information, use it for your benefit in medical management. And then about 15% of patients said that they felt their physician wasn't sure how to use the information. And again, the majority of those patients are patients that have worked with their primary care physician to get the screening ordered, and that's understandable. You know, many medical oncologists aren't familiar with ocular melanoma. It's going to even be a smaller understanding with the primary care physicians. So that's where some of those statistics that come in. I'm going to let Derek talk a little bit about his experience with the Medicare patients that he looked at with the expression profile.
So as a dovetail to some questions and perhaps even in the Dr. Hovland's talk, so Susan walked through the survey from 100 patients at Riverside. We had done for Medicare reimbursement purposes for the gene expression profile test a chart review of Medicare age patients in that time frame that I have up on the slide there in order to go ahead and reach agreement on policy coverage and reimbursement. And what came out of that as well is some interesting data which actually matches up exactly with what Susan found from a patient perception perspective, which was to say that we looked at the medical records of this group of Medicare patients who had the testing done. It represented in this time frame about 29 ocular oncologists, all in the U.S. The ex-U.S. customers we took out of the equation. And keep in mind that around 50% of the reporting results are going to be kind of a class 1 or low risk, and 50% about class 2 or high risk individual. Most physicians are going to have a base plan, right? They're going to either say, my comfort zone is we're going to be frequently monitoring patients every 3 months, 100% of them, unless I find that they're a lower risk, and then we can discuss that. And some are just the opposite, saying I'm more comfortable with a less frequent surveillance plan until I look at the clinical factors or the genetic testing factors, and I might increase that surveillance plan, right? So you'd expect roughly half to be changed or whatever. And the results we found in the chart records was around 60% of patients, once they had received the results, their physician had discussed with them and in fact had changed surveillance, which about matches up to what you might expect in sort of good practice with using those results from a clinical management standpoint. In that group as well, there's around 42% who refer to either adjuvant clinical trials or onto a melanoma oncology center for closer follow-up care for the high-risk patient population primarily. So again, the results, at least during this time period, which is around the first year or so of availability in the U.S., we're having an impact on patient care. And from our standpoint, that was important to be able to see, because that says that this test isn't being ordered just kind of for fun. There's actually something which is important here that's hopefully impacting care and improving quality of life and care downstream. And that's kind of the point there. And we thought we'd stop there. Dr. Hovland will be coming more in terms of what he sees in terms of surveillance management, et cetera. And maybe we should go to we have a summary slide and go back to some questions. So in summary here, prognostic testing, which is really genetic-based testing using either DNA and chromosomal assessment or RNA gene expression profiling, is really solely to improve or establish staging, more accurate staging for ocular melanoma once you have made the diagnosis of ocular melanoma. It's not for the diagnosis, it's for the prognosis only. The options are both an RNA-based and a DNA-based, so chromosomal testing produces this kind of footprint of a gene expression profile. For patients receiving eye-sparing therapy, it's obviously important, as we talked about earlier, that this is an awareness and a conversation that's made up front, because from our standpoint, we've miserably failed at Castle in the last couple of years to try and design a clinical study where we could do a pre-specimen and a post-plaque specimen, be able to come back and say, with our test it works, or with our test it doesn't work. And the default is to look at other literature which says radiation is going to change those genes enough where you can't reliably impact that. That's just what we're seeing today. However, if you end up having uniquely because of the location or size, etc., there's the option of either frozen tissue downstream or paraffin-embedded tissue that's been fixed in formalin. So those are options that one who has that mode of treatment has an option downstream if they want to. I think, as Dr. Sibilia pointed out in that one slide that Susan went through there, one of the early conversations that's still ongoing now, but more so a couple of years ago, was what are some of the complication risks, and will this in fact perhaps increase my risk of metastasis in that data in the hands of skilled surgeons? Doesn't appear to have a change, but there are complications, and that's part of the discussion we have with your physician. And at least from the survey here at Penn, and that mirrors earlier work published at UCLA in New England, patients who elect to undergo genetic testing generally don't have a regret of that decision to go ahead and do that, and that's always perhaps a downstream theory, I guess, at the end of the day. So I think that's the last slide, the last question we had. Do we want to go back to the questions here?
Well, my first question was, would genetic testing...
Excuse me, sorry to interrupt. Could you use the mic? If you have a question, just pass it around.
Would post-plaque genetic testing be of any help in determining the risk of OM in one's children and so on and so forth? That was my first question.
The majority of ocular melanoma is not an inherited cancer. We have about 1,600 tests that we have done. I have, without giving too much information, I only have one brother-sister pair. I have no other recurrence in family members. There are some indications with the BAP1 that are still being investigated about whether there would be a mutation in BAP1 that would indicate an inherited risk for developing ocular melanoma. So again, that could be done with blood testing, and if that's found to be clinically relevant, that we need to do that testing. It would be outside of looking at the tumor. We could actually do that on blood DNA.
Thank you. My second question was, what about genetic testing on mets that have already appeared in the liver? Does this, say for example, fine needle aspiration stuff, does this provide any help in determining prognosis and treatment? And do you guys do it?
I think what my impression has been is that, one, I'm going to default to the future with people that are going to talk about this in terms of the clinical trials. Yes, I know that there have been some biopsies that are being done. Going back and forth in terms of what's important, what should we be looking for? Yes, a biopsy can be done, but what needs to be looked at? What's the predictive value then, and what treatment is going to be most valuable? So yeah, any laboratory could do it in terms of be willing to do it. I think that there has to be documentation of, again, should it be done? What's the medical benefit of doing it? What's the data that we need from that?
Well, I would think the medical benefit might be determining treatment options.
Yes, exactly. But until we have that really strong data of what genes are we looking for, whether it's expression or chromosome changes, to determine those treatments, we don't have a good fit for information and treatment yet.
I think probably most of us would volunteer.
Yeah, I'm sure.
You are adamant in saying to us that this has to be pre-radiation, okay?
Yes.
Now, I happen to be treated by a doctor, I don't think I need this, who is adamantly saying that he believes he can, through vitrectomy, extract a post-radiation sample from which he can get genetic and chromosomal results that are reliable. Obviously, it can't be your test. It was somebody else's test. Can you expand on that at all?
One, I would have to see the data of what kind of materials. So the concept of the radioactive plaque, what you need to think about is a tumor incorporates genetic mutations in order to guarantee its survival. And so what we're looking at are what are those molecular genetic changes that are predicting how aggressive that tumor is at the time of diagnosis. When you place a radioactive plaque on that tumor, you're essentially causing so many other genetic changes that are fatal to the cell. And so what you would want to be careful about is, could genetic material be isolated from that tumor after radioactive plaque? Most likely. But how do you discriminate between what is indicative of the tumor biology prior to treatment versus changes that were caused by treatment that may not be indicative of the tumor biology? So I think that there would have to be enough of those tests, as Derek had indicated, doing that study to look at whether it's still predictive. Can we still give a prognostic answer post-plaque therapy?
Are those two tests competitive tests or sequential tests? And if they're competitive, what would be the accuracy of one or the other?
Good question. They are competitive tests. You don't really need to do one versus the other, although certainly you could to get that information. You're talking about accuracy. It's a big difference when you talk about the difference between a diagnostic test and a prognostic test. 99% of the time, we get an answer. Not always, a clear-cut answer, but you're giving a risk assessment. So yes, we can get an answer, but you're looking at then a risk assessment. So we put you into a profile of high risk or low risk. We actually classify patients as high risk, moderate risk, and low risk, and establishing kind of a soft number statistic based solely on the genetics. So the accuracy is high, it's reproducible, but keep in mind that it's not, if you think of something like hemophilia, genetic mutation confirms disease. It's 100%. You've got one versus the other, whereas this is a prognostic test. What's the chance that something's going to happen?
So we haven't done any direct comparisons as a company, but the group at WashU with Dr. Harbour and his clinical trial, other sites who are involved in this prospective clinical trial did complete all the research testing. And what they looked at was they compared this gene expression profile test to clinical factors like eye size, location, etc. They also compared it to a couple of different versions of chromosome 3 testing, although not what is being done at the University of Pennsylvania. There's an important distinction there. And in both the research work that was kind of looking back and this 5-year prospective work looking forward, the class 1, class 2 is more accurate than those methods in terms of being able to say, this is a low-risk patient. We had fewer people who might have metastasized. This is a high-risk patient. Most of them did. Now, but that again was using other chromosome 3 techniques, and one of the I want to sound like a commercial. So one of the opportunities I think that Dr. Harbour gave us as a company, and maybe he was patient, was rather than just having it be friends of Dr. Harbour who knew him, who could have samples be done there, or referrals from Will's Eye or around Pennsylvania where it's done there. Our test is available for whatever makes its perfect order. It's one test. It doesn't change platforms. Whereas in the Cleveland Clinic, one's a different chromosome 3 test, UCLA wants something different, and although the data generally lines up, you really have to look at that center's data.
And
I hope that wasn't too...
Yeah, no, it's fine. I was just going to say, the University of Pennsylvania is available to anybody also. We just have the strongest collaboration with the Shields and the Wills Eye Institute, so it's really right across town, so it's worked nicely.
I want to go back to your earlier question about, and maybe this is an OMF question, or maybe it's the University of Pennsylvania or Castle question too. So we were asked that last year as well, 2 years ago, how come you didn't screen out this test should be taken? And part of that from our standpoint was, one, is we're a healthcare provider, and although we're servicing you as patients, we really are servicing at the decision making that you made with your doctor and oncologist of what's right to do and is this the right test. And we're very uncomfortable getting directly involved in direct patient care, and that could be completely wrong. But that's just the philosophy we started off on. But we've been asked a few times about saying, why don't you publish the list of who has done your testing? And part of that is, okay, well, we want to get into a referral business. Is that something which is more appropriate from an OMF standpoint? But I wouldn't mind, I guess, comments or your thoughts, or anybody else's here, I guess, too, because you're right, the worst thing we can all do is to have you not be aware of it and not make an active choice. The best thing is to make an active choice. Whatever it is, that doesn't make a difference. But
I think you have to be bold about approaching these providers and just saying, look, this is available and you need to be talking to your patients about it. We have to be brave. We have to do all this research and be our own advocates and call these oncologists and these ophthalmologists and say, you need to talk to your patients. Can we put some brochures in the lobby?
I think we're prepared to fund an airdrop of literature. We talk about this, so the education needs to start at the ophthalmology side, and that's something my dad felt very, very passionate about. And I know for a lot of you, the debate about whether this is pertinent to you post-brachytherapy and what sort of genetic information you can extract from, say, tissue that has undergone radiation treatment, we can leave that up for debate. But I do want to recognize everyone here we view as vanguards of the OM community. You're very active in the listservs, so just to get that groundswell of information and make sure other people are aware that these are out there, to be talking about it, so someone who is just for the first time being told there are options, they have all information. And I'm a firm believer that knowledge is power, so the more data you can have as early as possible, the better. That's kind of where we came from.
I would really like all of us to be in a position to know if the oncologist we're seeing is on that list. Because if not, it enables us to push them if we know. If we don't know, well.
Yeah. Here's the deal. Those doctors, when they see other doctors on that list, they'll feel much more compelled to take action. It's all about status in that community.
That's right.
Exams, models.
Oh
yeah, it's a good question.
We do have probably one more question, and we're running about 30 minutes behind already, so I need to kick it over to Dr. Hoffman.
Prediction from the Anderson. Both tests would give the same information in terms of risk for tumor recurrence. However, the gene expression test will give additional information in terms of future choice of treatment, because you know which gene is lost expression, which gene is overexpressed, and we are having targeted therapies that are specific for those genes, and we can select treatment based on the additional information we get from gene expression.
One question.
I was treated at UNC in North Carolina, and they're a teaching hospital, and I was told, no ifs, ands, or buts, I could not have a biopsy. No, it was not even discussed. I was told no. Because this is a teaching hospital, now they are teaching all of these other students, no, 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 no. Is there some education that you are doing to go to these teaching hospitals and say, wait, yes, this is possible, it is good? Because I was told I could not have a biopsy because it would make my eye bleed and they wouldn't be able to monitor the tumor was the #1 reason.
Okay. Yes, we need to do education and identifying those physicians that have that philosophy. We can talk to them. Yes, I agree. And I would reiterate that if you went to one of those centers and feel that you are not given that choice, and that there might be a tumor specimen still available, you can talk. I've put an information sheet out on the table that's there in the lobby. If anybody has questions, I'm more than happy to talk to anybody about that option. It depends on how you
We certainly try and reach at Castle physicians who we believe are treating ocular melanoma. It ultimately is their hands. They're the one who's doing the biopsy. They're the ones who are discussing the risk and benefits with you. As a company, we can't influence that negatively directly because it's all based on comfort, I would think, and how I might use that. And all I would say is that compared to 2.5 to 3 years ago, there's far more ocular ophthalmologists or retinal surgeons who are comfortable saying, this is what we can do, but you're right, they all aren't there.
Right. It might be awareness of the quality of the testing that's now available that was not available several years ago.
Okay.
It's good.
Thank you.
Go ahead.